My name is Michael Deininger. I am the Chief Scientific Officer of Versiti and the Director of the Versiti Blood Research Institute, and my clinical institution is the Medical College of Wisconsin. So I presented an update on leukemia abstracts presented at the 2002 ASCO meeting, and I picked 4 abstracts that caught my attention. 2 are related to ALL and 2 are related to AML. The AML abstracts that I talk about are both related to the use of ivosidenib in patients with IDH1 mutations. As you know, IDH1 mutations are found in a subset of patients with AML. They are supposed to be founder mutations, and they are also found in subsets of patients with MPN and MDS. So this study tested a 3-drug regimen consisting of venetoclax, ivosidenib, an IDH1 inhibitor, plus minus the addition of 5-azacitidine. This was a relatively small study with small cohorts with the goal of determining the recommended phase 2 dose. In this patient population, the regimen has remarkable efficacy, especially the triple combination, and that means a high rate of complete response, or CRI, and a very significant proportion of patients achieved molecular clearance of the IDH1 mutation. So I look forward to seeing the phase 2 study take off, because I think that this could be a really effective regimen for patients with IDH1 mutations. Toxicity was mostly musculoskeletal and GI, but very manageable altogether. So bear in mind that this is close to a non-chemotherapy regimen. There was an abstract looking at ivosidenib efficacy and molecular responses in a trial that was a randomized trial between azacitidine and versus azacitidine plus ivosidenib. And in that trial, I think the remarkable feature is, well, unexpectedly, the responses are better for ivosidenib compared to placebo. Remarkably, the patients who did achieve molecular clearance, about half of the population, it turns out, were typically able to maintain that. So it seems that once this clone has been addressed through the treatment, then responses tend to be really stable. Now let's talk about 2 abstracts on ALL. One is Ph negative ALL. This is a long-lasting study from MD Anderson that is basically trying to improve therapy for older patients with ALL, specifically patients over the age of 60. The initial regimen tried was a heavily reduced hyper-CVAT with dose reductions of all agents and elimination of the anthracycline, combined with the anti-CD22 drug conjugate inotuzumab. Now in this study, 50 of patients, the regimen was changed from an 8-cycle, fairly intense induction regimen, followed by maintenance with pump, to a short induction with lower doses of inotuzumab, where part of the induction was entirely replaced by a non-chemotherapy regimen consisting of blinatumomab. And then the maintenance is blinatumomab in alternation with pump. Now, all in all, the response rate in this study is very encouraging. What we didn't learn from the study is to which extent the change of the regimen has already impacted results, because the issue is less efficacy and less relapse, but still toxicity, probably owing to the older population plus the still relatively high chemotherapy dose, both in terms of the hyper-CVAT regimen, mini hyper-CVAT, as well as the relatively high dose of inotuzumab. The overall survival in this cohort is only about 50%, but the event-free survival is much higher, indicating that many of the patients did succumb not to leukemia, but to complications of the regimen. And in fact, it turns out that 31 out of 80 patients had died because of complications, septicemia mostly, and secondary AML and MDS. So the hope is that with this adjusted chemotherapy-free regimen in the future, the results will improve for the older patients with ALL. I think the most exciting development perhaps in Ph-positive ALL is again an MD Anderson study that looked at a combination of ponatinib with blinatumomab, so entirely chemotherapy-free, in patients with newly diagnosed Ph-positive ALL, relapsed refractory Ph-positive ALL, or lymphoid blast phase. The overall response rate in the newly diagnosed patients is almost 100%. One early death to intracerebral hemorrhage and one late death unrelated. All other patients maintained response. So it seems to me that for this patient population, the combination of blinatumomab plus ponatinib is going to be the future. I should mention the study itself is induction, then consolidation of 5 cycles total, followed by maintenance with ponatinib at 15 milligrams. So these 4 abstracts I thought were what excited me most in the realm of leukemia, but I'm sure more is to come. Thank you.